I will talk about the restrictive practices and the changes, the recent changes around the legislation with those, and we'll just go through things, and then if you have any questions, feel free to ask at the end. So first of all, what are restrictive practices? So the definition is any practice or intervention that has the effect of restricting the rights or freedom of movement of the care recipient. So it's fairly broad, and we'll go through the different types later on. So from the 1st of July, there have been some changes to the Aged Care Act and the Quality of Care Principles, which were last updated in 2014. And we'll go through the recent changes. The amended legislation requires providers to satisfy various conditions before and during the use of any restrictive practice. So you've got to actually document any alternatives to the restrictive practices that you've considered or used and why they've not been successful. You're also required to have a clinical governance framework in place to minimize the use of restrictive practices. So if you are using a restrictive practice, then that framework exists to ensure that you've got informed consent from the patient or the substitute decision maker. So obviously in most cases, it would be the substitute or decision maker rather than the patient themselves who can give appropriate informed consent. Restrictive practices are used. The patient or consumer must be regularly monitored for any side effects or any signs of harm coming from that particular restrictive practice, and you've got to review it regularly, aiming to remove it as soon as possible, if that's practical. But at least you've got to be reviewing and thinking about it. Whereas I think very often, as we all know, things get started when somebody is, quite agitated or whatever it might be, and then it just stays on their, on their medication chart forever. So this is trying to address that. So from the 1st of September, providers are required to have a behavior support plan in place for every consumer who exhibits behaviors of concern or any changed behaviors, or who has restrictive practices considered or used. The Quality and Safety Commission focuses on ensuring that risks to patient safety, health, and well-being through the use of restrictive practices are minimized, and that consumers are treated with dignity and respect. Because, as you all know, with drugs, for example, they've all got pretty significant side effects, and we've got to be, really careful about, considering the whole picture before we, put people on these drugs and continue their use. So you may get a restrictive practices compliance notice where, if you haven't, the facility hasn't complied with the responsibilities around using a restrictive practice appropriately. So the Aged Care Commission has the sort of regulatory power to respond to instances of non-compliance, and that's detailed in this document, the Compliance and Enforcement Policy. So we'll go through the different forms of restraint. So first of all, and I guess most commonly used, is chemical restraints. So that's the practice or intervention that uses that involves the use of medication or any sort of chemical substance in order to influence the patient's behavior. But it's important to note that that does not include drugs that treat a mental disorder. So, for example, your antidepressants or anti-anxiety medication are not chemical restraints. Drugs that treat a physical illness or any sort of physical condition. So those drugs don't enter the category of chemical restraints. And similarly, end-of-life care. So if you're using certain drugs for end-of-life care, for example, we may use haloperidol at the end of life. That doesn't, again, enter the remit of a chemical restraint. Moving on to environmental restraints. So that is the practice or intervention that restricts or involves restricting a consumer's free access to all parts of their environment. So it might be, restricting access to an outside space. It might be, shutting a door or, otherwise preventing the patient from using a particular part of the facility or entering another area. Also, limiting the use of an item that they need in order to mobilize. So, putting their walking frame out of reach so that they can't actually physically get up and that sort of thing. So that's an environmental restraint. So a mechanical restraint is using a device to prevent or restrict a patient's movement in order to influence their behavior. So it would be things like, using wrist restraints or something to, secure the patient to the bed or something like that, which, is really, not not appropriate, really, unless it's, for example, an intensive care setting where the patient may have an ET tube and, and you restrain them to prevent them pulling that out. But really, apart from that sort of setting, a mechanical restraint, really not be appropriate in most instances. So, but it wouldn't include, for example, say using a wheelchair or something like that, which they require for their mobility, but which they can't get out of. But you're using it with the purpose of, not to restrict their movement or behavior. Physical restraint involves the use of physical force to actually, restrain or subdue the patient or, sort of restrain a part of their body or something like that. So if, say a patient is, wandering off somewhere that they shouldn't, and you, place a gentle hand on their shoulder or their back and say, no, not that way, you need to go this way, and you just gently guide them the other way, that is not, a physical restraint, but, actually sort of physically, holding, someone down, preventing their movement, that would be a physical restraint. So seclusion. Now, this is where a patient, where you use sort of solitary confinement of a patient, where they cannot exit voluntarily, and you use that for the purpose of influencing their behavior. So, obviously, if they are in a single room, that's a different matter. That is not sort of deliberate seclusion, but choosing to seclude somebody as as a means of controlling their behavior, that is really not acceptable, and we shouldn't be using that form of restrictive practice. The requirements for using any form of restrictive practice, we should be using it as a last resort, with the aim of preventing harm to that person, or to other people, so staff or other consumers as well, and only after careful consideration of the impact that this restrictive practice could have on that particular person. So wherever possible, you should have tried to use alternative strategies before you start using the restrictive practice, and that should have been documented accordingly. We tried diversional therapy, that did not succeed, et cetera, and therefore, we were compelled to use this particular restrictive practice. We've also got to make sure that the restrictive practice used is proportional to the necessity, and in proportion to the level of harm that is potentially caused to that to particular person, or the risk to others, and that is used in the least restrictive form and for the shortest time. We should also be sure to get informed consent from either the person themselves or their person responsible. And I think traditionally, we haven't been all that great at doing that, because we would just prescribe it if required, and this the need to get informed consent is, I think, not something we focused on, but it absolutely should be, and we've got to be quite mindful of that, because as I mentioned before, these drugs have quite significant side effects, including stroke and mortality, so it's not negligible. And we've got to ensure that the use of these restrictive practices complies with the provisions of the care and services plan of that particular care recipient, or their behavior support plan. And we've got to make sure that the restrictive practice complies with the aged care quality standards, and of course the appropriate state or territory. Prior to using restrictive practices, you've got to make sure that a full assessment is conducted by an approved health practitioner who's got day-to-day knowledge of that particular person. So they should have assessed and documented that there's a risk of harm to either the person themselves or to others, and therefore that the restrictive practice is necessary. And that restrictive practice should be in accordance with the principles outlined. And if it's a chemical restraint that is being used, then the assessor and prescriber should be a medical practitioner or a nurse practitioner. The provider should be certain that the assessment has taken place and that consent has been given as well. Going into more detail with the assessments for chemical restraint. So got to document the assessment and decisions made during that assessment, and why you need this chemical restraint. If a chemical restraint is used, the provider is responsible for ensuring that the prescriber is given information about the effect of that particular restrictive practice. Is the drug working? Is it not working? That feedback should be given. The patient is very drowsy, etc., so that adjustments can be made. In an emergency, of course, things are a little bit different. So you should still try to consider whether an alternative strategy may be effective. And, but certainly there is, some leeway, for example, in terms of getting informed consent and that sort of thing. You may not have time, of course, in an emergency, and you may have to do what is necessary at that moment. But, there still should be some thought given as to what alternatives you can use. And the Quality Commission will review care and service plans where emergency use of restrictive practices has been applied. And if there's, evidence or recurring evidence that insufficient action has been taken to avoid emergency use of these things, then they may take further action in that instance. What are our responsibilities when we're using these restrictive practices? You've got to make sure that the consumer is being regularly monitored for side effects, signs of distress or harm, and changes in their well-being or their abilities to, perform their own activities of daily living or other functions. The necessity and effectiveness of that practice must also be considered on an ongoing basis. And if if the patient is actually quite calm, their behaviors are settled, perhaps they no longer need it, or at least need, a lower dose. And we should always be thinking about that and whether, there's scope to actually minimize or cease the use of these restrictive practices. And some thought should be given as to whether some environmental changes can be made that would reduce or remove the need for the use of the restrictive practice. Behavior support plans. So these plans should set out the information about the consumer. So the provider or a prescriber should be able to understand the consumer's background and their behaviors. So it should include any assessments that have been carried out about those behaviors, any effort made to identify triggers, alternative strategies which have worked in the past, what's worked, what's not worked, and the restrictive practices that are used for that particular person once the alternative strategies have been tried and presumably failed. Then this is what we will do, and there should be clear documentation of that for each person. As we mentioned already, providers are required to have a behavior support plan in place for every consumer who's got restrictive practices applied. So this is part of their overall care and services plan, and that should include, as I said, consent from the consumer or substitute decision maker. There are various resources available to help to develop these behavior support plans on the Quality Commission website. So, we've given the web address there, and, it might be useful to just have a look and, have a little look at the resources they've got on there. It's quite handy. Consent. So the prescriber of a chemical restraint is responsible for obtaining informed consent for that medication. Informed consent should be obtained prior to using the restrictive practices or medication, except of course in an emergency. So informed consent means that the consumer or their substitute decision maker has been given the information, and they should have had the opportunity to review that information and ask questions, and then have been given time to actually make that decision. So clinical governance framework is the set of relationships and responsibilities established by a health organization to ensure good clinical outcomes. So it helps to ensure that everyone, involved throughout that care process, so from the clinicians at the front line to managers and all the way up to the executive, is held accountable to the patient and the community for ensuring that we deliver high quality healthcare, which is continuously improving. Who is involved in the clinical governance framework for restraints? So you've got the care recipient and the authorized representative or family member, next of kin in the middle, and then you've got lots of people, professionals involved in their care. There's nursing staff and care staff. There's workforce involved in upskilling. There are pharmacists, geriatrician, general practitioner, and a care provider and an organization. The organization has a responsibility to implement a clinical governance framework that has the overall aim of minimizing the use of restraints, including ensuring that informed consent is obtained. And they should ensure that policy and procedures comply with the Aged Care Act and the quality standards. And the organization also has a responsibility to ensure that the employee workforce has an appropriate skill mix to effectively minimize the use of restraints. So in terms of nursing staff, the roles and responsibilities there would be to establish a behavior support plan for every consumer who has behaviors of concern or who is under restraint, ensuring that the ongoing use of restrictive practices complies with the behavior support plan, and ensuring that the prescriber is given regular feedback as to the effectiveness of these measures, and regularly monitoring the patient for any signs of distress or harm. In terms of care staff, everyone's got a responsibility to undergo any required training, ensuring that all care activities comply with the behavior support plan, and reporting any relevant changes or concerns to the nurse or supervisor. The GP should ensure that the medical care is provided in a way that complies with the restrictive practices obligations. And the prescriber is, as we already said, responsible for obtaining informed consent. And they should be also reviewing the necessity of using the restrictive practice on an ongoing basis, and they should be coordinating multidisciplinary input for these patients. As far as the geriatrician goes, as a responsibility to provide specialist geriatric assessments and interventions for these consumers under restrictive practices, ensure a timely review and report following the GP's request for this assessment, providing high-level participation in developing the consumer's behavior support plan, and supporting care providers and GPs to achieve quality outcomes for these patients. Choice Geriatrician can help you with these restrictive practices frameworks and behavior support plans. So Choice Geriatrician is a subsidiary of Choice Aged Care and forms a part of the Royal Commission or post-Royal Commission integrated services solution. So we provide telehealth services that focus on the person, but also helping the organization to meet their compliance requirements. So it's a GP referral that's needed, and we bulk bill, so there's no cost to the facility or to the patient. And the consults are facilitated by an on-site professional, usually a pharmacist, and then there'll be a geriatrician via the telehealth link. We use a referral form that looks like this, and it's the form is aligned to the clinical governance framework that applies to the care providers. The pharmacist is the residential medical management review pharmacist. They can provide expert input and interventions for these care recipients with a behavior support plan or who are under restrictive practices. They can help ensure timely review and report following the GP's request for a medication review, and they can help to support prescribers to minimize the use of chemical restraints, and again support the care providers and GPs to achieve quality outcomes relating to chemical restraints. Choice Aged Care, the medication reviews are aligned to the client care providers' restrictive practices clinical governance framework. Last year, across 15% of aged care beds in Australia, the Choice Aged Care medication reviews achieved a 20% reduction in antipsychotic prescribing. So that's pretty significant. It's a very good result. QUM pharmacists provide medication advisory services relating to chemical restraints. They support consumer engagement and informed consent. So there are QUM digests that are produced, which are handy sort of information sheets on sort of various relevant topics. I'll show you a few examples. They deliver routine webinars. They can attend resident or family meetings. They can provide staff training, resources and guidelines on using restrictive practices, and they can disseminate other resources and training to GPs as well. And there are some clinical tools that have been developed that can be really useful. So there's a PPAS-3 tool, which I believe you've all been given access to. And they also produce monthly and quarterly drug use evaluation and quality reporting. So these are the QUM digests, so quality use of medicines. There's one on, various different topics, so dementia and BPSD, and then there's, handy summaries on each, on sort of commonly used medications that are used for the purpose of chemical restraints, so they can be really useful in explaining, how to use these drugs, when they're useful, when they're not useful, side effects, all that sort of thing. So they can be pretty handy to go through. With the so staff resources, so there's on-site and online training topics. So, for example, physical and chemical restraints, care-based therapies, psychotropic solutions, antipsychotic use, and there are some guidelines and posters on there as well. So I would encourage you to have a look at those resources. They can be really useful and have a lot of good information. We can also support you in obtaining informed consent. There are some forms as well that have been developed by Choice Aged Care that you can use to sort of guide your discussion. And, it's just a very clear way to document, the reasons why you're using it, and, the discussion that you've had, and and the relevant signatures. So this is the PPAS-3 tool. So that stands for psychotropic polypharmacy and antimicrobial support for standard 3. This is a quarterly review that's conducted by a clinical pharmacist and a geriatrician, and then some physical restraint protocols and reporting are being developed. It's under development, and there's industry benchmarking and drug use evaluation as well on psychotropic and chemical restraint use. So the registered training organization has a responsibility to deliver quality and industry relevant training to the aged care workforce. It should align training with the organization's workforce upskilling strategy and make sure it complies with the clinical governance framework, and should also provide training that enhances the workforce's capacity to minimize the use of these restraints in the first place, and to provide quality care to those patients who are already under a restrictive practice. The National Care Academy is a national footprint of RTOs with the dedicated purpose of providing workforce upskilling solutions in relation to the single quality framework and Royal Commission recommendations. So there's training on dementia support, behavior support, etc.